Hello. Yes, sir, can I have a question?
Am I audible now?
Yes, sir, you are audible. Hello.
Somebody, you can start. Please unmute yourself. Vineetha, am I audible?
Yes, sir.
Somebody, what's the issue with at your end? Vineetha, please give me a minute.
Am I audible now, sir?
Yes.
Okay. So may I present this? I will share the slide, sir.
Okay. So, good evening, everybody. So today we are having the second session on integrated course in pain and palliative medicine. So today we'll be talking about the basics of pain, which you have already covered through your learning management system. And today's our faculty would be Dr. Vineetha, who has done her MD in anesthesia, followed by a fellowship in pain management from HCTPA Lucknow, and also from Jagadia, Kolkata. She recently completed her fellow in international pain practice from World Institute of Pain, USA, and she is currently practicing as a pain physician at KIMS Health, Trivandrum, as well as a visiting consultant in Pallium. Her areas of interest include interventional pain management, regenerative medicine, neuropathic pain, cancer pain, and palliative care. So she has worked in palliative care for about 2 years with us. So welcome, Vineetha, and it's over to you.
Thank you, sir. Am I audible?
Yes, you are.
Okay, I'll share my screen, sir. Okay, is my screen visible, sir?
Yes,
It's visible, sir?
it's visible.
Yes, yes.
Okay. Audio clarity is less actually. I'm hearing the audio clarity. I'm getting it less. I don't know whether it's a problem with my connection. Then I'll start. So good evening all. Again, I feel very happy and privileged to take this class for Pallium India and the ICPM course. So today's class is an introductory kind of class for pain management. And in the second session, we will, in the part 2, we will deal with specific opioids, opioid prescription and everything. And in this class, it's just, an introduction to the basic concepts of pain management. And I know most of the delegates attending this session are physicians, oncologists, anesthetists. So I don't think I will be telling anything new, but the whole idea is to sensitize you to this basic concepts of pain management. Okay. So to start with, I think all of you already know what is the definition of pain. The International Association for Study of Pain, IASP, has put forward this definition of an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. But we don't need such a long definition to understand what is pain. In simpler terms, pain is what the patient says hurts. So whenever I get a chance to take a class on pain management, I'll tell my audience that if you want to take only one point from this session, it is this: believe your patient. Okay. And the concept of total pain, I think this has been already covered in the previous session. So the pain has got not just the physical component, but the psychosocial, the psychological, social, and the spiritual components. So irrespective of the diagnosis, irrespective of the type of pain, irrespective of the location of pain, whatever be the painful condition is, you have to plan a comprehensive pain management program including all these aspects of total pain. Then only we will be able to improve the quality of life of the patient and the family. So I'm not going into the details because it has been already covered in the last session. Now coming to the classification of pain. So the temporal classification of pain is like this into acute and chronic. Acute means less than 3 months and chronic means more than 3 months. Then another classification based on the nature of pain, the pathophysiology we can say is nociceptive pain, neuropathic pain, and nociplastic pain. So the nociceptive pain is what happens when the tissue nociceptors or noxious stimuli is there and the tissue nociceptors are damaged, activated, and that causes the nociceptive pain. Neuropathic pain, the newer definition is a lesion or disease of the somatosensory system. An identifiable noxious stimuli may be there, may not be there, but there is some lesion or disease of the somatosensory nervous system. And what is a nociplastic pain? Basically, I like my classes to be interactive because otherwise after some time you will sleep and after some more time I'll also start sleeping. So anybody has any idea of nociplastic pain, what it is? Because you can be wrong, no problem, but that attempt to say the answer, that itself means a lot when we are taking a class. So if anybody has any idea what is this nociplastic, this is a newer terminology. Any idea?
You can unmute and speak.
Pardon?
Dr. Bharat, no, Dr. Bharat says it is visceral pain.
No, actually it is a state of central sensitization. Nociplastic pain, the conditions like fibromyalgia, the chronic post-surgical pain syndrome, where there is no identifiable noxious stimuli, there is no identifiable tissue or nervous system injury or disease, but the patient is having pain. So it is actually, this term refers to the pain conditions in which there is sensitization, central sensitization. Okay.
There is another answer by Dr. Yamini. So
Yes.
says altered pain sensation like sand and limb.
Altered pain sensations. Yes, we can say that the altered pain processing. rather than altered pain sensation, altered pain processing conditions. These come under this nociplastic pain. I don't know, my screen is not working. Just a minute. Okay. Now, so we told about the temporal classification into acute and chronic pain. So this is a very simple but yet very important aspect that we all should know, because even today morning, one of my staff nurses was telling, ma'am, don't write fender patch for that patient because she doesn't appear to be in that much of pain. Don't write, just give placebo. I didn't have time to give a detailed lecture, but I just told it's lack of your knowledge, not the patient's problem. So basically, there is a difference in the pain behavior when it comes to acute and chronic pain. In acute pain, the patient will be wincing, crying. There will be a lot of sympathetic activation like palpitation, tachycardia, sweating, and the patient appears to be in distress, and we believe when the patient says that he or she is having pain, we believe that. Whereas in chronic pain, the patient is used to this pain for 3 months or more. That is the definition of chronic pain. So there is some state of adaptation. The patient comes into some kind of an adaptation. The patient is still in severe pain. If you ask the pain score, the patient will tell us 10 by 10. He or she will be in a desperate situation. There will be lack of appetite. There will be lack of sleep. He or she may not be able to go for work. He or she may not be engaging in the social activities. But again, the patient will not appear to you as in a distress. So this is a difference between acute and chronic pain. So whenever you are dealing with a chronic pain patient, cancer or non-cancer, in my practice, I'm dealing with more of, after my fellowship, I'm dealing with more of non-cancer pain patients. And this is a even more serious problem in non-cancer, because in cancer, we know that the patient is having this cancer. So we tend to believe the patient. In non-cancer, the patient comes with back pain, neck pain, the pain here, pain there. All the investigations are normal, and chronic pain means the patient will not appear to be in a distress, even though he or she tells a pain score as 10 by 10. So we tend to blame, or we tend to, put it like this. It's all in your head. So this is something very basic and very important that you should carry it in your mind from right now, that chronic pain behavior is different from acute pain behavior. Okay. Now coming to the next classification, that is nociceptive pain or neuropathic pain. So I have seen this tendency even with pain management physicians. That is, the moment the patient says that my pain is not controlled on analgesic, we just go up the analgesic ladder. But we need to spend some time and try to figure out what is the cause of pain, what is the etiology, what is the pathophysiology, and what is the nature of the pain, whether it is nociceptive or neuropathic. Because as I told before, nociceptive means the nociceptors are getting activated. There is some noxious stimuli and causing nociceptive pain. And usually the nature of the pain will be throbbing, aching, catching. Whereas in neuropathic, it's a lesion or disease of the somatosensory nervous system, and the nature of the pain will be burning, shooting, scalding, tingling, that kind of a pain. So it is important. Your patient may have both this pain, nociceptive component as well as neuropathic component. So it is important to find out which is the predominant component. In our hospital, there is a protocol that if any patient comes to the emergency or gets admitted with a pain score more than 8 out of 10, we start the patient on fentanyl PCA, patient-controlled analgesia. So this has happened that one, I think, diabetic neuropathy patient with severe burning pain in the legs came to ER. He also had UTI and many other problems. So he got admitted under internal medicine department. So that at night, the patient was started on this fentanyl PCA. And the next day morning, I got a consultation. And when I went to see the patient, the staff nurse and the duty doctor, they both were talking to me like this, that, ma'am, I think the patient is malincurring. He's having some functional issue, because we started the patient on fentanyl PCA, that too around 100 microgram per hour, 100 or 125. Still the patient is saying the pain score is 8 out of 10. How is that possible? So that means the issue is something else. So again, here the issue is not with the patient, it's with the physician or the staff nurse, because again, it's a lack of knowledge. Because what is the difference here? The nociceptive pain, it responds to the traditional analgesics very well, NSAIDs, opioids, whereas neuropathic pain, it poorly responds to our traditional analgesics, be it opioids or NSAIDs. So can you tell me which are the opioids that have a better effect on neuropathic pain? Can you put it in the chat box? Which are the opioids? Is very good. Methadone, I got an answer. Again, I need two more. Fentanyl, no. Tramadol, again, very good. Again, tramadol has a brother, sister, tapentadol. Tramadol, tapentadol, methadone. These three are correct. One more is there. Actually, no. Textbook says these three, tramadol, tapentadol, methadone. But if you, yes, somebody has told the correct answer. Buprenorphine, Dr. Abraham has told it. Buprenorphine has also got a good effect in neuropathic pain. Because why, you can go and search the literature for the role of buprenorphine patch in diabetic neuropathy. You will get the answer. There is something called this pertussis toxin linked G protein. And this G protein appears to be less in neuropathic pain conditions. So morphine will not act. This morphine, fentanyl, all these are G protein coupled receptors. So these traditional analgesics will not work, and buprenorphine works in a different way. So this buprenorphine does not depend on this pertussis toxin linked G protein. So that is the reason why buprenorphine is also effective in neuropathic pain conditions. So if at all you want to give opioids, give either tramadol, tapentadol, methadone, or buprenorphine patch. And methadone is not available in my hospital. Recently, we have acquired it. It was not available. And my favorite is so either tramadol or buprenorphine patch. So we'll come to that later again. So this is important. Don't give your patient morphine or fentanyl and the patient is not responding. And if you say that it is functional or something else, it's actually not correct. Okay. You need to know to, and of course, we need to start the patient on neuropathic pain medications, but none of the neuropathic pain medications will work overnight. So we need to give some analgesics to cover that window. That is why we should know which opioids will act for the neuropathic pain. Okay, just a minute. It will take a few minutes before I can go to the next slide. There is some issue here. Okay. The next thing is a little bit about the pain physiology. So what happens to the chronic pain over time? So what happens to the chronic pain over time? Does it increase in the intensity, the amplitude, and or is it it decrease, especially if it is left unattended or not adequately treated? What happens to chronic pain over time? So the answer to this, it lies in this physiology of pain. So we know that it starts from transduction, transmission, modulation, and perception. So the pain pathway, it is not a fixed wired circuit. There is something known as modulation. So this modulation of this pathway can be an excitatory modulation or an inhibitory modulation. Most of the time, when you don't treat your chronic pain adequately, what happens is the excitatory modulation, otherwise known as sensitization. So sensitization has got a peripheral component and a central component. What happens in the periphery at the level of nociceptors and what happens in the dorsal horn, which is known as central sensitization. So I don't have time to go into the details, but after the class, if you ask me, I can explain on this. So the net effect of this sensitization is in the periphery, the sleeping nociceptors, they get activated. In the dorsal horn, the adjacent spinal segments also get recruited or activated. So what happens over time is the area of pain increases, the severity of pain increases, the threshold of pain stimuli decreases, and it comes to a state that even touch becomes painful. So the net result of sensitization is primary hyperalgesia, secondary hyperalgesia, and allodynia. I hope all of you know all what these terms mean. If there is any doubt, we can discuss it at the end of the session. So all these hyperalgesic conditions, primary, secondary, and allodynia, these are the result of sensitization. Okay. So this has also happened before. One staff nurse told me, when I went to put the cannula, even when I'm touching the patient's hand, the patient is crying out in pain. Ma'am, this is functional. So I am repeating these case scenarios, this incident again and again, because I again and again every day I keep hearing this from my colleagues. That's why throughout the presentation, I keep, telling these scenarios. These are the scenarios in which we tend to blame the patient's, psychological status, but the answer to all these lies in the pain physiology and not in the patient's brain. So our target should be to treat early and treat well. Treat early before the sensitization sets in or becomes severe. Now coming to the assessment of pain, so we know that we have to take a detailed history and we have to do a clinical examination and we have to review the investigations. By the time the patient reaches us, or he or she may have all the investigations done. So in the history taking, the most important three aspects are, one is we have to listen. I think you all know the concept of, active listening. Just listen properly. And second, believe the patient. Don't think the patient is just, blabbering like that. We have to believe the patient and we have to show empathy and compassion. The patient doesn't need our sympathy, but we have to show empathy and compassion. And what are the objectives of this pain assessment? So we need to find the characteristics of pain. As I told before, we need to find whether it is nociceptive, neuropathic, is a radiating pain or a focal pain. So we have to find out the characteristics. We need to get an idea of what is the etiology, pathophysiology, and the other factors, the other components of total pain contributing to the pain experience. So you can use any of this, mnemonics to get these characteristics of pain. You can either use PQRST, the palliative factors, provocative factors, quality, radiation, severity and impact, and temporal factors, or I use Socrates, site, onset, character. I think all of you might be already knowing that. Okay, so any of this, but the most important is you have to go about it systematically. So this has happened. I think Sunil sir only has told this story when I was doing my fellowship, that a patient was referred from a tertiary care hospital to Pallium, India for intractable abdominal pain. So that patient was a case of a CA pancreas, and they have done all the investigations possible, and they couldn't find out why the pain is not responding to any of the analgesics. And a detailed history taking, it just came to this that it was just constipation. Okay, so it is very important that we should not take things for granted. Like the patient is having CA pancreas, obviously abdominal pain will be there, right? It's not like that. We have to take a detailed history and we have to give attention to detail and find out what may be the patient is having intractable pain, not responding to analgesics. What may be the cause? Okay, so for that, we have to go about it systematically, either use PQRST or Socrates, or go about that history taking very systematically so that you don't miss anything. Then the tools for assessing the pain intensity, we have unidimensional tool like NRS, visual analog scale, phaser scale, where we just measure the pain intensity, the physical pain intensity. And we also have the multidimensional pain scales like McGill's and brief pain inventory, where we also assess the patient, how much it is affecting the patient's the daily course, or the cognitive component, the affective component, the emotional component. When we are assessing these dimensions also, we can use this multi-dimensional scales. So these are the examples of the unidimensional scales like NRS, visual analog scale. It is very important. It's very important for any pain patient coming to you. You should document the pain severity. If you are dealing with pain, You can be an oncologist or a pain physician or an anesthetist, whatever be your primary specialty. If you have to inculcate that palliative approach or a approach to your primary branch, whichever it is, whenever you are dealing with a pain patient, you have to document the pain severity. It is actually Gopal sir says that it is something kind of a criminal negligence or something like that if you are not documenting the pain severity for a patient in pain. It is equivalent to that. So this is an example of a multidimensional pain scale, Meckel pain questionnaire and brief pain inventory. This is another one that I constantly use. I told initially that patient may have nociceptive as well as neuropathic component. So you can use this questionnaire, DOLA neuropathic 4 questionnaire, DN4 questionnaire. You can keep the printout of this questionnaires in your OPD and you can ask the patients to fill. So there are 10 descriptors in this. And if the patient score is more than 4 out of 10, then the patient's pain is predominantly a neuropathic pain. So you can, this will help you in better, more efficient management of pain by choosing your agents wisely. Rather than just, going up the analgesic ladder. The patient was on tramadol, I'll just go to morphine. Not like that. We can decide what is the nature of pain, what is the type of pain, and we can add adjuvants accordingly. So you should use this DN4 questionnaire in your clinical practice. Now coming to the certain general principles regarding the management of pain. So this is a multimodal, multidisciplinary pain management. So we have a 4-step approach. So first is correct the correctable. As I said, an example of constipation, electrolyte imbalance, or anything that can attribute the patient's current situation, any correctable infection, we should correct that. Then non-pharmacological measures like physiotherapy, psychotherapy, and other components of total pain. Then we have the pharmacological measures depending on whether it is nociceptive pain or neuropathic pain. And then we have interventions, which can be percutaneous interventions or surgical interventions. So coming to the pharmacological measures, so we all know the WHO analgesic ladder. Earlier it was a 3-step ladder, and in 1986 when it was formulated, later a 4th step including interventions was added, and also WHO made it bi-directional. But it is not necessary you have to always go from step 1 to step 2 to step 3 in that direction. The patient is having severe pain, we can start from step 3 also. Okay. So the step 1 is non-opioid analgesics like NSAIDs, paracetamol plus minus adjuvants. Step 2 means the weak opioids plus step 1 plus minus adjuvants. And step 3 means the opioids for moderate to severe pain plus step 1 plus or minus adjuvants. So coming to the opioids, so we will be dealing with opioids in detail in the next class, the practical aspects. So just an introduction of the basic concepts of opioids. So the recent classification of opioid receptors is mu, kappa, delta, nociceptive norepinephrine receptor, and the zeta receptor. Earlier there was sigma receptor, but now they have excluded it. Then this is the classification of the opioid analgesics. We have the pure mu agonist, which is again divided into natural opioids like morphine, semi-synthetic, and synthetic, in which comes epinephrine, methadone, fentanyl. Then complex action opioids, in which we have agonist, antagonist, mostly kappa agonists like naloxone, pentazocine, butaphenol, and partial mu agonist plus kappa antagonist, just buprenorphine. And we have pure opioid antagonists like naloxone, naltrexone. And the mechanism of analgesia, we know it's mainly mediated to mu receptor, but kappa and delta receptors also mediate analgesia. Tramadol, why it is effective in neuropathic pain? Because it has got an action, it inhibits a reuptake of serotonin and noradrenaline. Thereby, it amplifies the descending inhibitory pathways. Earlier, when I talked about modulation, I told there is excitatory modulation and inhibitory modulation. So this tramadol and this, through the inhibition of reuptake of serotonin and noradrenaline, it amplifies the descending inhibitory pathway. Methadone, it has got the same action, inhibition of reuptake of serotonin, noradrenaline. Along with that, it has got NMDA antagonism. That is why methadone and tramadol are effective in neuropathic pain. And due to NMDA antagonism, methadone can reverse tolerance also. Okay. tolerance, hyperalgesia, such situations. And the equipotent doses, you can go through this later. So the buprenorphine patch, I usually start with the 10 microgram patch, and this 10 microgram patch is equivalent to around 24-25 total daily dose of morphine, oral morphine. And fentanyl, usually we start with 25 microgram per hour, which is equivalent to 60 milligram of oral morphine per day. And what are the side effects of opioids? Side effects are the adverse effects that occur with the normal therapeutic doses. Constipation is the only side effect that will last as long as the patient is taking morphine. All the other side effects, usually it lasts for around 3 to 5 days, and they are self-limiting. So that is why we say that the hand that writes opioid should write a laxative also. Whereas, what are toxic effects? Toxic effects and side effects are different. Toxic effects are the adverse effects when the administered dose is higher than that required for pain relief, or when the pain has poor response. If the pain is not responding to the opioid, the patient will not have pain relief, but the patient will have drowsiness and all this delirium, myoclonus, respiratory depressions, everything will come. So you have to observe whether the pain is responding to the opioid or not before you titrate up the opioids. Then coming to the adjuvant analgesics. So what are the examples of adjuvants? The most commonly used adjuvants are the antineuropathic agents. Then we have corticosteroids for inflammation. As an anti-inflammatory, we can use corticosteroids. Topical agents like topical local anesthetics, lignocaine patches, capsaicin. Then bisphosphonates for bone mets and pathological bone fractures in all those situations. So I will be just talking a little bit about the neuropathic pain adjuvants or anti-neuropathics. So this is a suggested neuropathic pain ladder. The first line we go for gabapentinoids like pregabalin, gabapentin, then SNRIs like duloxetine, venlafaxine, then tricyclic antidepressants, amitriptyline, nortriptyline, and for focal neuropathic pain conditions like post-herpetic neuralgia, we can go for topical agents like lignocaine, capsaicin. So these are considered the first line agents for neuropathic pain. Second line means a combination of the first line drugs or tramadol. But tramadol I use as a first line because none of these works overnight. Then third line are the selective serotonin reuptake inhibitors like sertraline, anticonvulsants like carbamazepine, NMDA antagonists like ketamine, and interventions like sympathectomy for sympathetic mediated pain. Fourth line is neuromodulation, and remember, low-dose opioids are considered a fifth line. So I have seen this tendency with pain physicians that a patient in severe neuropathic pain, there is a tendency to go for opioids directly. If they are not responding to the gabapentinoids, they go for fentanyl or oral morphine. So that tendency is actually wrong. The role of opioids is as a fifth line when we have tried. Of course, neuromodulation is not in our hands, or it is very less done in India. But all these three steps we can try before we try this strong opioids. Okay, and the sixth line is targeted drug delivery like intrathecal pumps. And in neuropathic pain, it is important that you choose the right drug for the right patient. For example, an elderly patient is coming to you with radiculopathy or neuropathic pain, or it's a cancer patient only, but he is having a neuropathic pain. It's an elderly male patient. Which will be your drug of choice? Anybody? An elderly male patient with a neuropathic pain, what will be your, I told the first line are tricyclic antidepressants, gabapentinoids, and SNRIs like duloxetine, venlafaxine. So out of these agents, elderly male patient with neuropathic pain, what will be your first drug of choice? Oh, it can vary from physician to physician. I'm just asking what will be your drug of choice. Sunil sir, can you tell me what are the chat options? Because when I'm taking the chat option, the screen is getting stuck.
Gabapentin.
It's amitriptyline, gabapentin, pregabalin. Yeah.
Okay, so basically, I told specifically elderly male. So my choice would be gabapentinoids, either pregabalin or gabapentin, especially gabapentin, because elderly patients may not tolerate pregabalin. Why not amitriptyline? Is amitriptyline can cause urinary retention, or elderly males means they may have this benign prostatic hypertrophy, but not just for that. Elderly patients tolerate amitriptyline poorly. So my first choice would be gabapentinoids, is that too gabapentin more than pregabalin if it is an elderly patient. Now my question is, a female or a young female patient who is having a neuropathic pain and she's having mood disturbances. Okay, so what will be your drug of choice?
Amitriptyline.
Amitriptyline. Anything else?
Duloxetine,
Yes.
TCA.
Actually, both duloxetine and TCA are right, but duloxetine has got more, inhibition of reuptake of serotonin than noradrenaline compared to TCA. So maybe duloxetine, but TCA is also a correct option. Duloxetine or TCA you can use. And if the patient is having sleep disturbance, so my choice, I would say, if the patient is having mood disturbance, I will go for duloxetine. If the patient is having, the mood is okay, but some kind of a sleep disturbance, I will go for an amitriptyline, because amitriptyline is more sedating actually than duloxetine, so the patient will get a better sleep with amitriptyline. That is how I go about it. Now my question is, a diabetic neuropathy patient, maybe around 50, 60-year-old, not that old, diabetic neuropathy patient with a burning kind of pain in his legs, what will be your drug of choice? Here I'm specifically telling it is diabetic neuropathy. Any answers?
Gabapentin.
Okay, I'll come to that because
Pregabalin.
I'll come to that. So this is what I have told. In elderly patients, gabapentinoids is a first choice. Altered mode, either TCAs if it's young TCA, but older patients, SNRIs. I generally prefer SNRIs for altered mood. And if it is altered sleep, I'll prefer TCAs. Then disease-specific conditions are there. For example, trigeminuralgia, the carbamazepine or oxcarbazepine is the first choice. Focal neuropathic pain, like PHN, postherpetic neuralgia, topical lignocaine or capsaicin is a choice. Now, this is what I asked. Diabetic neuropathy. There is something coming up known as phenotypic management. That is depending on the nature of the pain. So if it is a burning, tingling, or a pin-pricking kind of pain, then duloxetine is a drug of choice. If it is an evoked pain, like, or a paroxysmal pain, like intermittent shooting pain, then we go for gabapentinoid. So you can go back and you can research, you can do a Google search on this phenotypic management of diabetic neuropathy. You'll get a lot of articles on this. So this is something coming up and very promising for diabetic neuropathy. For other neuropathy conditions, this is not yet established. For diabetic neuropathy, there's a lot of evidence to support this phenotypic management. Okay, now these are the, just I have given in my slides, anti-neuropathic agents, the common doses and side effects. You can go through that later. And finally, about interventions, the percutaneous interventions in pain management. So we have this nerve blocks, myofascial injections, intra-articular blocks using local anesthetic steroids. We have radiofrequency ablation now, thermal radiofrequency and different types of radiofrequency ablation. Then chemical neurolysis, commonly we do for cancer pain, alcohol, phenol, or glycerol. And we have some advanced techniques like intrathecal pump, spinal cord stimulation, right? And among these interventions, the maximum evidence is for celiac plexus neurolysis for upper abdominal malignancy. This has got the maximum evidence. Now, so before we conclude, the question is, how adequately are we treating pain? So this study has found out that in taking all the stages of cancer together, almost 50% have moderate to severe pain. The incidence of moderate to severe pain is 50%, and in advanced malignancies, it is 70%. And this is the prevalence of cancer pain. We can see that around 40% is a prevalence of moderate to severe pain in the cancer patients. And in metastatic or advanced cancer, it is around more than 65%. But are we treating pain adequately? So this is actually shocking, right? In mild pain scores, when patients having mild pain, we are giving adequate pain relief to 50%. Rest 50% we are treating it inadequately. In patients with moderate pain, we are in 80% patients, we are not able to give adequate pain relief. And in severe pain patients, 94.3% patients, we are treating pain inadequately. We are not able to give an adequate pain relief. But why? Why are we not able to treat pain adequately? So is it because we underestimate pain? As I told before, are we systematically taking a history examination, systematically looking for a cause of pain? Are we using any tool like an NRS or VAS to document the severity of pain? So this study has found out that when patients rate their pain as moderate to severe, the oncology fellows fail to appreciate severity in 73% of cases. Another survey found out that the main reason or behind the patient and physician evaluation of severity. Sorry, the main reason behind inadequate pain relief is a discrepancy between the patient and physician evaluation of severity. The patient is same as having severe pain, but the physician feels the patient is having only a mild to moderate pain. So that discrepancy is a most common cause for inadequate pain relief. Then the recent study in 2018 found out that the pain was underestimated in almost quarter of patients, 25% of patients, especially in those with severe pain and female patients. So what are the barriers to pain relief? One is the attitude towards pain, that many of us, including pain physicians, many of us think that it's after all pain. No, as I have written in this right side image, nobody dies due to pain. So it can be, you can bear it, it's after all pain. Secondly, underestimation of pain. Nobody documents it systematically. Or nobody estimates it correctly. Most of us fail to estimate the pain severity correctly. Then misconceptions about painkillers. Many are afraid about NSAIDs. Many are afraid about opioids, and there is something known as opiophobia, the fear of respiratory depression, the rarest side effects of opioids, the respiratory depression, sedation, and even addiction. Then under-prescription and unnecessary suffering. So these are the barriers to pain relief that we commonly encounter. So to conclude, this actually it is not October, September 2010, this International Association for the Study of Pain, IASP, they had an international summit of pain, and they had this Declaration of Montreal. They put forward this Declaration of Montreal, which said that the access to pain management is a fundamental human right. So pain is what the patient says hurts. When he or she says it does, we have to believe the patient regarding his or her pain. And every day we have to tell ourselves that the access to pain management is a fundamental human right, and nobody should be denied of this pain relief. Thank you.
Okay, thank you, Vineetha. And I think now it's the time for you to clear your doubts regarding the modules that you have gone through, the pain modules 1 to 4, and also medical ethics. If any of you want to talk, please unmute and speak.
Is tramadol contraindicated in children?
Actually, the literature says that it is contraindicated in less than 12 years. But practically, we have given.
What about bone pain? What type of pain it is, and how what is the best method for controlling bone pain, and how we can differentiate between the bone destruction pain as well as versus neuropathic component of the bone pain.
Bone pain, usually it has got an inflammatory component as well as a neuropathic component. So how we go about it is usually, and we will be simultaneously giving bisphosphonates or the modalities for calcitonin, bisphosphonates, or along with all these things, that will be on one side. And on other side, for immediate pain control, we can give short course NSAIDs initially, that for severe pain. I have seen that the response to morphine is less, especially in the low doses. So initially we give paracetamol, NSAIDs, and also start the patient on a strong opioid. And some patients with bone pain respond to morphine very well, but some patients I have seen the response is not very good. And along with that, we start the patient on the bisphosphonates, and that is how usually we go about this bone pain. Sunil sir, if you want to add anything. And also neuropathic, we'll add, because in bone pain, usually there will be a neuropathic component also. So that is why we use this DN4 questionnaire, or we try to find out from the history what if the patient is having the neuropathic pain features, then we will start them on gabapentinoids or anti-neuropathic pain medications also, along with opioids, paracetamol and NSAIDs and bisphosphonates.
Yeah, Dr. Abraham mentioned about palliative radiation.
Exactly.
Yeah.
Yeah, that is usually done by the radiation oncologist. And from pain physician point of view, this is how I manage it along with palliative radiation.
Ma'am, is there any legal requirement as to who can prescribe opioids or who can prescribe all these pain medications? I mean,
Yes, yes. But for strong opioids, there is this request. At least in Kerala, I know. Is there any regional difference, sir? Kerala, there is our government mandates that we should have completed this some basic course so that we can prescribe strong opioids.
So, any modern medicine doctor or a doctor with the BDS can prescribe any medicines, including opioids. But the question is that even if you prescribe and give it to the patient, where would the patient go and get it? It is not available in pharmacies, the strong opioids. Tramadol might be available, tramadol would be available, but morphine, methadone, those are not available in, or codeine as of now is also not available in pharmacies. So it would be available only in those institutions who has got a recognized medical institution status from the drug controller of the state. So they will be stocking and dispensing this morphine, fentanyl, methadone, etc. But even if the patient brings a prescription from somebody else, then that institution, they may not respect that prescription, because they don't know who is sending this prescription. Will this person know how to prescribe opioids? Is he trained in pain management? So all these are questions. But theoretically, anybody can prescribe any opioids.
So you're telling that to keep it in to keep a stock of morphine, then also what is the requirement?
Okay, so there are two types of licenses. One is that the institution can apply for the recognized medical institution status, RMI status, if they have a doctor who is experienced in palliative care and pain management. But even individual doctors can apply for a personal license. But with that, only 100 milligram, I think 100 milligram of morphine can be stocked by a doctor. That means 10 milligram tablets, I think 500 milligram, probably 50 tablets only. So that
for the doctor to stock that, he need to have a license, right, sir?
Yeah, the doctor needs a license, but
Yeah,
it is not according to,
okay.
Yeah, to get RMI license, the procedure is very easy, but to get the personal license, it is a little complicated.
Okay, that's what
the
prescribe is not
anesthesia
needed, but to keep it as a stock, we need a license. That I have read in Kerala government guidelines. So I thought it's to prescribe, but it's actually to keep the stock. Okay.
Can the anesthesia department can stock morphine?
If you want to get recognized medical institution, you need to prove that you have experience in pain management and palliative care, and then apply to the drug controller. Then only you will be able to stock the tablets of morphine or methadone. Even this is available through another method, that is ND3 license or something like that. But it is through another route. You have to apply to the local excise office. Then local excise office will forward this to his higher authority, and then it will go up to the topmost position, and then will come back. It is cumbersome. But if you become an RMI, then the procedure is fairly easy. You need to apply to the drug controller. Drug controller will send a representative to your institution. He will come and look at some of the things at your hospital, and he can then provide you with the recognized medical institution status. So it is not only anesthesia department. Anybody can stock and dispense, but there are certain prerequisites. And the most important one being, the doctor should have experience in pain management and palliative care.
Ma'am, can we use multiple agents for neuropathic pain, or can we combine multiple agents for neuropathic pain?
Yes, actually, that's what the ladder I discussed told. First, you start on a first line agent, which is either a gabapentinoid or a tricyclic antidepressant or a selective noradrenaline reuptake inhibitor, SNRI. So, or if it is a focal neuropathic pain, you can go for topical agents. So, either one of these four, that is why I gave some clues, like whether it is an elderly patient, altered mood, altered sleep. So, all these will help you to, choose one particular agent initially. And you start on a lower dose, because most of these agents will have this dizziness and all these things. So you start on a lower dose and titrate gradually. Meanwhile, you can give tramadol for immediate, or buprenorphine patch. Buprenorphine patch is expensive, that's a problem. So depending on that, you can give an opioid for immediate pain control, but start on one particular agent and you titrate it. If you feel that you are not getting a good response, then you can combine these agents, the same first line agents. For example, I go about it like this: start on pregabalin, 50 milligram or 75 milligram, then make it 75 milligram BD. And if the patient is not getting adequate relief, add tryptoma, that is amitriptyline. Start with 10 milligram, then 25 milligram. So that is how we go. But we definitely can combine. And many patients with severe neuropathic pain, they will require more than one anti-neuropathic pain medication. And the most important point is, before doing that, don't go on for morphine. So because if you directly go on to morphine or fentanyl or buprenorphine can be used in that short term, but that acute phase. But if you go on to morphine before combining this anti-neuropathic agents, the net result will be a morphine-dependent patient who is having the same neuropathic severity, with same severity of pain as before. But he has one additional problem to deal with that now. That is a dependence. I'm telling about non-cancer patients, neuropathic pain in non-cancer patients.
Hello.
Yes.
Regarding the SSRIs, I
Yes.
was reading in the material that SSRIs are not useful for any pain, but you had mentioned that SSRI
Yes, actually this ladder, I have given that reference. This ladder says to include SSRI as a third line, not as a first line or second line. Maybe because of the associated, these patients with chronic neuropathic pain, they will have definitely a component of anxiety, depression. So they have found that particular ladder such as SSRI. Generally, SSRIs are less useful, and in my practice also, I have not used sertraline for any pain conditions, but it is included as a third option. That's it. You can give a trial.
Does it act as a pain relief or a mood stabilizing?
Maybe more because of the as a mood stabilizer.
That's because in the module they clearly say that it has no pain relief action anywhere.
But if you do a Google search, if you do a literature search, you will get a lot of articles commenting about this. SSRIs for various pain medication, various pain conditions. Most of them are done on fibromyalgia and conditions like that, where there is a component of psychological aspect is also there. So maybe the pain relief is due to that. We don't know. But if you do a literature search, you will get a lot of articles. I have read and this ladder also says to use SSRI as a third line. But generally, speaking from practical experience, no.
Okay.
I won't use.
Okay. And regarding this license, as an anesthesiologist, we'll be practicing from day one for the pain relief.
Yes.
And we'll have the opioid license also, like injection fentanyl and morphine injections. So with the same license, can we procure oral morphine and other oral opioids?
I think it's a different, no, you need a different license.
Yeah.
At least in the institution I am working, I have worked with several institutions. We needed separate license to prescribe oral morphine.
Yeah, oral morphine would need another license.
Okay. With this course, we can apply once we are through this course, we can apply it through our name, through my name.
Yes, you can.
Okay, thank you.
Any more questions? Okay, Dr. Abraham is asking. Yeah, please go on.
Yeah, actually, when we decide for an intervention for pain management, second, if the patient has got a period of relief and then if the pain come back again, so how do we assess?
I didn't get your question. When will we select the patient for intervention? That's your question, sir?
Yes, that's part number one. And how do you maintain the pain management after the intervention?
After the intervention, okay. So in cancer pain, for example, we are having a CA pancreas. The whole idea of, suppose the patient is not responding to, we'll start the patient on opioids, say morphine. So if 5 milligram, 10 milligram, we have gone up to 10 milligram, the patient is not responding well to opioids, I would go for an intervention. See, we can even scale up the opioids morphine now. But as the patient's, the disease severity and the severity of the pain progresses, it becomes very difficult for them to lie on the prone position for the block. Not only that, now the literature says that early intervention and early adequate pain management, this actually, it's not just about pain control, it actually improves the patient's compliance with the the treatment as such, the chemo, radiation, and the, that compliance with the cancer treatment also improves. So now it's like more towards an early intervention. If maybe for 5 mg or 10 mg Q4H morphine is not giving the patient adequate relief, and we have something like a celiac plexus block, which has got very good evidence for upper abdominal malignancies, I will go for it. But now the question here is, can we stop morphine completely with the celiac plexus block? The answer is no. We may not be able to provide 100% pain relief just with celiac plexus neurolysis. We may be able to provide 100% pain relief for 1 month or 2 months. The duration of celiac plexus is for 6 months. Celiac plexus neurolysis is like 6 months. Minimum, there will be 6 months duration. But we won't get 100% pain relief for this 6 months. So we will have to tell the patient initially itself. The whole idea of doing this procedure is not to completely stop the morphine, but we can maintain the patient on a low dose morphine for the duration of action of the neurolysis.
Ma'am, and after 6 months, can we repeat the
Yeah,
block?
we can repeat. Definitely, we can repeat.
Thank you. In connection with that, basically when we are looking at, there are few doing palliative care are less into interventions. We are pulling on the patients maximum with the medicines, and the intervention may be kept for the last. There are different thought processes are there in even in the palliative, pain medication for these patients. So my question is different. Where will you put a team of doctors to assess pain management for these patients?
Pardon, where?
What is your team of doctors?
Yeah, my team of, okay. So definitely, you're talking about cancer pain, right, sir?
Yeah, yes.
So in cancer pain in our hospital, the team includes definitely the oncologist, the medical oncologist, radiation oncologist, and then we have a my pain and palliative care physician. I have another, my colleague is there who is doing only palliative, and I am the interventional pain physician in the team. And we have of course, the physiotherapist, nutritionist, psychologist, very, very important, because in cancer pain, there will be a lot of emotional, that total pain component also. So all of us actually work together, and I generally tell my palliative care, physician, my colleague, that don't escalate the opioids too much, because if it is not controlled on a low dose opioid, say 5 mg or 10 mg Q4H, then she will refer to me for any possibility of interventions. And at that point, we will discuss the benefits and risks with the patient. And I'll clearly tell the patient what to expect. It is not like 100% pain relief, one intervention, we'll be able to stop the morphine completely. It's not like that. What to expect, I'll clearly tell the patient, and the patient is willing, then we'll go for the intervention. So that is how we decide.
Thank you.
Dr. Abraham has asked a question. Is there a limit to the amount of morphine that can be prescribed at one time? So did you mean the dosage or number of tablets?
Number of tablets, sir.
Okay. So there is no such rules or clauses in NDPS Act, but we should understand that we have to prescribe and make the patient comfortable, but we also have the responsibility that the patient is going to use it properly. So it would be good to prescribe maybe for 2 weeks if the patient is coming from nearby area, or if the patient is from a far distance, then maybe for 1 month. Otherwise, don't prescribe it for 6 months, 3 months, etc.
Thank you, sir. Ma'am, I had one more question. You had talked about the pain that is not controlled in patients, like the mild, moderate, and severe pain. One thing I have seen is that a lot of patients, they don't follow the schedule. You say by clock also for pain management. So for patients who do not follow the schedule for taking the medication, do you suggest some other modality like a patch, or do you transition to something else?
Yeah, definitely. You can go for sustained release preparations and patches. If the patient is, we will be discussing that in the next class for poor patients with poor complaints. So we can definitely go for sustained release preparation. Which you can give it as, BD or patches. And one more thing I see in Kerala, I don't know about in your states, patients also have this opiophobia. Okay, because when you just told that they don't take by the clock, so especially patients who are coming from not just about by the clock, they don't take it intentionally, because they from the day one they also try to keep the opioid dose to the bare minimum. Okay, even though we prescribe it as Q4H, they will come and tell us, I'm taking only TDS. It's fine because I'm, afraid to take more. So this opiophobia is there with patients also, especially those in a middle class or in a higher socioeconomic status. They do a lot of Googling and they don't take it this fourth hourly, even if we prescribe so.
Thank you, ma'am. I've seen that actually not only for morphine, some patients take paracetamol also once or twice a day, saying they want to reduce the amount of drugs that they're taking.
Yes, correct.
So there are a lot of misconceptions among patients regarding every medications, and most of the time the pharmacist will act as the doctor, and he will be giving the instructions. Who wrote this? Who asked you to give paracetamol 6 hours a day? It will damage your liver, kidney. So there are many problems.
And even doctors also. This
Yeah.
because doctors having this because of they also have this opiophobia and this lack of awareness regarding morphine. So I had a patient who was on morphine 5 mg Q4H. So he went to a neurosurgeon and the neurosurgeon asked him like, you are taking 5 mg morphine, oh my god. So this is a basic, the starting dose is 5 mg Q4H, but the patient came back, he literally threw the tablets in my table and said, I don't want this. I'm taking a large dose. Sorry.
So I think we have to go for the patient story presentation now.
I have one more doubt, just last doubt.
Yeah.
Do you have any experience with subcutaneous injections in the patients for pain treatment?
So
Like in the module, I saw there there are several questions regarding the subcutaneous management for few patients in the home treatment. So what is your experience with the subcutaneous treatment, subcutaneous injections?
So when we admit patients in our inpatient unit for inadequate symptom control, not only for pain, but for many other symptoms, we usually give continuous subcutaneous infusion of medications, usually morphine, fentanyl, then these are the morphine and fentanyl are the commonly used opioids subcutaneously, and there are many other medications which can be given subcutaneously.
How do we exactly do that? Can you elaborate a little on it?
I think
Subcutaneous.
you can use the lowest bore needles, that is butterfly, 24 gauge,
Okay.
and put it subcutaneously, just like insulin injection, but with a 45-degree angle, and just pick up the subcutaneous fat with one of your hand, and then put the needle into the subcutaneous fat, the butterfly. Before that, you have to fill the tubings of the butterfly with the medication what you are going to give, and then you can either
we are going to
use syringe pump, or even you can give bolus doses, but the amount of injection and the volume of the injection should be less as much as possible, maybe 1 ml at a time, because otherwise that can sometimes produce pain. But if you are giving continuous subcutaneous infusion, then a very small amount is going into the subcutaneous area that will not cause any pain.
What is the rate and dilution?
It all depends on the how much amount the patient needs, and are you going to use a syringe pump or syringe driver? But a smaller amount of drug
you can just
would be
mention the range of.
Sorry.
You can just mention the range of infusion, like.
No, I cannot mention because I have given 5 milligram or 10 milligram over 24 hours. or I have given even
Okay.
maybe 100 milligram over 24 hours. So it all depends on the patient's pain and many other factors. So you have to always titrate. That's the basics.
Okay. Thank you.
Somebody, I think now we'll move on to the patient story.
Sure, sir. Sure, sir. I will play the slide.
So Dr. Yamini would be presenting today's patient story. Dr. Yamini, you can present now.
Good evening, everyone. My name is Dr. Yamini Baviskar, and I'm a radiation oncologist at Cancer Centers of America, Nashik. Today's patient, she's a 60-year-old lady who is diagnosed to have a locally advanced carcinoma of tongue, stage 4B squamous carcinoma, who have progressed after 2 cycles of NACT. The presenting complaints were pain over her tongue mass radiating to both ears for a duration of 6 weeks, which has increased over last 3 weeks. She has an ulcerative mass over left side of tongue that limits its movement for 3 months and difficulty in her mouth opening for the last 5 months. The pain is moderate in intensity, usually persistent, but it increases at night and is relieved once the patient is busy in her household chores at daytime. It causes disturbance in her sleep more before bedtime that causes her difficulty to fall asleep. The pain score intensity is 7 out of 10. The patient does not have a prior history of formal analgesic use, but she was using some Unani medications for some time. The functional limitation due to her disease is inability to eat solid due to trismus and inability to speak and swallow well due to the tongue mass. She also has generalized weakness after 2 cycles of chemotherapy and overall poor nutrition. History of illness, she has no known comorbidities. History of betel nut chewing for 40 years, and she had a past history of pulmonary tuberculosis treated 20 years back. In July 2023, she presented with an ulcerative lesion over her tongue, the biopsy of which was squamous carcinoma. An MRI was done for her, which showed a 4.5 centimeter lesion in the left lateral side of the tongue, involving the base of tongue and lingual muscles. And there was an ipsilateral level 2 lymph node, level 1B lymph node. No metastatic workup was done, but she had no complaints either of suggestive of any metastatic disease. She received 2 cycles of chemotherapy and after that defaulted and took Unani medicines. After this, she presented to our hospital where an MR showed a 5.5 centimeter lesion that had progressed, reaching the left tonsillar fossa and left oropharyngeal wall, crossing midline and partially encasing the left internal carotid artery. She had bilateral neck nodes suggestive of progressive disease. A CT thorax showed no lung mets. Next slide, please. On examination, the patient's general condition was fair. The performance score was 70%. She was conscious and oriented. She weighed only 37 kgs, which is averagely or thinly built, poorly nourished. She had mild pallor, no other systemic findings. On local examination, she had severe trismus and mouth opening was only 1 centimeter. She had poor oral hygiene and ankyloglossia. She had a 4.5 centimeter into 4 centimeter mass involving left side of tongue, posteriorly reaching the base of tongue, crossing midline, and involving the medial half of the right side, laterally involving the left tonsillar fossa and the left lower alveolus also. She had left level 2 and level 3 lymph nodes, which were mobile and 1 by 1 centimeter form. Treatment, she was surgically, it was an inoperable disease. She was unfit for any curative intent chemotherapies also. So the main goal of treatment as discussed in our tumor board was palliation of symptoms. She was planned for high palliative external beam radiation to a dose of 40 gray in 16 fractions to head neck region and an NGT insertion to improve her nutrition, pain management and social support. Significant investigations that were her blood work were all within normal limits. Creatinine was about 1.03 milligram per deciliter, and the creat clearance was 34 ml per minute. Psychosocial aspects were challenged. Next slide, please. So she is a 60-year-old illiterate lady separated from her husband with no children of her own. She earlier used to live alone with little support from her relatives and husband. But after diagnosis of cancer, she started living with her sister and her son, who also has a wife and child of his own. Patient is unemployed, and the primary source of income for the family is her nephew, who's a shopkeeper, and has to feed his wife, child, and his mother, and now the patient. Patient receives some amount from her separated husband, but the primary caregiver is patient's nephew, who is not available round the clock because he himself has a job. And the patient is distressed mainly because of her symptoms of pain and trismus. She is scared and reluctant of her treatment, but hopes for a miracle cure, unwilling to accept the gravity of her present disease condition. So she has not been fully made aware of her prognosis, but the attendants have been explained about her guarded prognosis, and they are trying to help her in turns, which causes multiple treatment breaks due to unavailability of caregivers to bring her to the hospital. Next slide. Along with external beam radiation for control of local symptoms, the patient is on pantoprazole 40 mg OD before breakfast, tramadol 50 mg thrice a day, tablet PCM 500 mg twice a day, pregabalin capsule 75 mg at night. She's also on Clozin lozenges thrice a day, and dexamethasone was started for 3 days during the course of RT after 10th day, 2 mg BD for 3 days. She's on syrup Dufalac also 15 ml STS and syrup Nucane gel for 20 minutes before food to help her with swallowing. She also has intraoral application of mucopain and alloderm application for skin for application at night. She is being asked to do salt and soda gargles regularly at 2 to 3 hourly intervals, and she's unwilling for NG tube insertion. The main concern for her is pain relief, nutrition, financial burden of treatment, and lack of caregiver support. To summarize, Mrs. R is a 60-year-old lady with locally advanced tongue cancer that progressed after 2 cycles of chemotherapy. She is symptomatic for the tongue mass that causes radiating pain to both her ears. She also has severe trismus, limiting her food intake. She is thin-built, poorly nourished, and weighs only 37 kgs. She is unfit for chemotherapy and is currently receiving palliative intent external beam radiation to control her pain and tongue mass, but with multiple treatment breaks due to unavailability of the caregiver. She is unwilling for NG tube insertion, has extremely poor financial condition, and is being cared for by relatives in turns, which makes it difficult to track or verify her analgesic use. And she hopes for a miracle cure for her disease. Next slide. So the points to be discussed in class based on patient story is regarding her pain relief and adequacy, if whether she can be started on step 3 or strong opioids, and availability of opioids, as at present in our hospital I don't have access to morphine, and caregiver counseling and patient counseling in terms of redefining goals of treatment.
Thank you, Dr. Yamini. So, other anybody who has any comments on the points raised by Dr. Yamini? Please give your opinion.
How is she maintaining her nutrition, Abhi?
She's taking orally only, so her mouth opening is hardly 1 centimeter, but she's taking only liquids and purees by spoon, and she is being fed about 2 hourly by her relatives. And we had attempted putting an NGT. We had counseled the patient earlier, so she agreed. But then after just about 2 to 3 hours, she had desperately was asking to remove the NGT, and she was not willing to put it back. So as of now, she's not willing for NG tube insertion.
Is she able to take the tablets for pain management?
Yes, so they are being crushed and given to her with the food.
This is similar to what I had asked earlier. For these sort of patients, also maybe something like a patch would be helpful. So please comment.
Okay,
Maybe
anybody
even
has
a
any
Voveran
comments on
patch
that?
or a Voveran patch or a fentanyl patch may be helpful for her for pain management.
Patches are often extremely costly, and as she told, the patient is from a very poor background. She's barely making her ends meet. So, and getting patches in government setup is next to impossible. We might get morphine, but we never get patches, except maybe in central institutes.
Central Institute Palliative Care do have patches for supply. So I think Central Institute Palliative Care support can be taken in such situations.
So presently in our institute, we have access to buprenorphine patch alone, which is extremely expensive and not for morphine, oral morphine or any other fentanyl patch.
What about her oral hygiene now? Because she's anyway, she's her mouth opening is critical.
Yes,
She's
yes.
to the oral cavity, and she can always have secondary infection that can add to the pain. So how do you manage that situation?
So an antifungal lozenges, the clotrimazole lozenges, he's been asked to take it, just keep it in the mouth for 3 times a day so that she does not develop a fungal infection of the oropharynx and oral cavity. And also with radiation, she may have certain amount of mucositis that can also precipitate secondary bacterial infection. So to avoid that, she has salt and soda gargles that will help prevent mucositis.
Vineetha, what's your opinion?
So if oral morphine solution is available, then that is a good choice in this patient in view of restricted mouth opening. So I would go for that if it is available, but as morphine is not available, then she might need to be referred to a place where morphine is available. She need to be put on strong opioids because her pain control is very much inadequate. That's one. Another point that I wanted to add. If morphine is available as aqueous solutions.
What is the kind of pain she is appreciating at this point of time? Is it has got a definite neuropathic component? So should we act on that part as well?
He's already on pregabalin, I think, right?
Is that adequate?
Only 75 milligram.
So what do you think, Dr. Yamini? Do you need to add on that? How will you like to optimize that?
That can be made twice a day, pregabalin, because she's on pregabalin, paracetamol twice a day, and pregabalin at night. And tramadol she's taking thrice a day.
What were the neuropathic features in her history?
The pain is radiating to both her ears. So she has a tongue mass predominantly of the left side. But
So it is infiltrating the glossopharyngeal nerve you are trying to tell.
Yes.
Okay.
What about nerve blocking at that situation?
See, glossopharyngeal nerve block can be done, but the problem is glossopharyngeal neurolysis is very difficult. Not difficult. The problem is it's very close to the vagus. Okay, and along with internal carotid and all, so it's very technically very difficult to do a glossopharyngeal neurolysis. So it will block the vagus, and the patient will go on to bradycardia and all the problems. So another thing is, if it is in the anterior tongue, we can go for a trigeminal because it's supplied by the lingual, which is a branch of mandibula. In the posterior tongue, it is we can do a glossopharyngeal repeated nerve blocks with LA steroids to break the vicious cycle of sensitization. But in long term, there is not much role. And another, sometimes there will be a sympathetic component to pain. This kind of cancer pain also, when it is tongue and all, there may be a sympathetic component. So sometimes, stellate ganglion blocks helps in such patients. So these are the possible interventions.
Is
Dr.
it
Yan,
possible?
I just
Sorry.
want to ask, how much of the pain do you think right now is due to the disease, and how much do you think is due to the post-RT reactions?
The pain as of now after the analgesics is about 4/10, 4 to 5/10, and it increase. So during the daytime it would be somewhere about 4 out of 10, and at night it goes to 5 out of 10 with the present analgesics. And with RT, she does not have increase in symptoms apart from the mucositis. So that she has had after 10 to 12 settings of radiation. So that is well controlled with local application of mucopain. And her mouth opening has partly improved. So it is now 1.5 centimeters to about, so expected to be about 2 centimeters by the end of 3 to 4 weeks after completion of RT.
Is it possible for us to have a peg inserted in her for better nutritional status?
What inserted, ma'am?
Endoscopic, the gastric, this thing we can insert, no? Peg insertion.
Yeah.
For feeding.
That could be an option if she does not respond to radiation and she continues to have dysphagia, because she is completely unwilling for a nasogastric tube insertion.
No,
maybe
nasogastric.
surgically
Sorry, nasogastric tubes are quite difficult to tolerate in most of the patients, especially for long term. So PEG is one method by which most of these chronic patients can be given adequate nutritional support, and their, what do you call, the pain relief, the tablets, etc., can be given through that. So in your
that would
center,
also not be, the surgery would also not be costly, I guess. It should be a simpler one.
yeah, but it's endoscopically you can get it placed.
Okay.
It's not a surgical method. But you will definitely need anesthetic support.
Okay.
Why did this patient wanted to remove the nasogastric tube? Any idea?
It was partly because because it was causing discomfort, and partly because she did not want the tube coming out of the nose. So mainly because she did not want the tube coming out of the nose. So that was one major reason.
Okay. So one thing is that the dose of tramadol you can increase, and up to 400 milligram per day is the recommended dose.
Yes.
If morphine is not available, so that can be done. And regarding the placement of PEG, it all need to be discussed with the patient. And if you as a treating doctor, if you feel that she has maybe more than 3 months to live, then you might discuss with the patient. There is a procedure, something like this, insertion of PEG, how it is inserted and what is its benefits, and what are the harms that can be done. So these things need to be discussed with the patient, and take the patient's opinion before you proceed to any interventions.
Right, sir.
And regarding the paracetamol dose, I think that can be increased, maybe 15 milligram per or even 12 milligram per kilogram body weight. At least every 6 hourly need to be given to the patient.
Okay. Okay.
On a prevention point of view, just this is a bad situation. So is our counseling anyway upfront at the time of decision making could have avoided the situation? What's your opinion?
So, before you do any procedure or anything to the patient, it is a good practice to discuss with the patient so that they can understand what to expect from that interventions. So they can take their own decisions. Even if we feel that, okay, this can be good for the patient might not have that feeling. It all depends on patients, what they want with their body. So I think that needs to be inculcated into our practice.
That has to be, sir, but definitely the patient does not know what exactly is going to happen, and that is why we are having that expertise to know what exactly is going to happen for these patients. So definitely we have got a definite right to say that, or to make the patient understand that this is probably the course of the disease, and these are the things. What is your opinion on that? Because many of times it is the unawareness that take the patient for alternative treatments, and patients do come back with curable malignancies in a very advanced situation. And then we are talking about all of these sort of psychosocial support, where we are unable to do that at a point where the patient actually needed one to take a proper decision. That is a question I have put in.
So the treatments, so maybe there would be many patients who would be going for many types of treatment. But if somebody comes to us, then only we can intervene, isn't it? Otherwise, it would not be possible from our side to intervene, because they might not be reaching to us. So I think what we need to do is improve the awareness of the society regarding what needs to be done. And even there are a lot of misconceptions regarding not only about cancer, but also about many other diseases. So unless that is improved, then all these things can happen.
Definitely, I think we should tell them in detail about all the modalities available for, like in this case, nasogastric tube insertion or this PEG insertion. We should tell all the pros and cons, all the expected benefits, risk. But I think it's the patient's choice to, make a decision. That's the patient's right. So, but slowly, when the patient is admitted and the patient is with us, every day we should talk to them and explain to them these are the modalities available. That is our duty, to make them aware. These are the things available. But we can't stand on their shoes and take a decision. The final decision has to be by the patient.
Dr. Yamini has mentioned that the patient is in denial about the diagnosis. So what do you suggest for that? That is one thing that you very commonly see in both the patients and the caregivers.
Okay, so we have some sessions coming on communication in which we will deal it detail, but for as of now, if the patient is in denial may be a coping mechanism as well. Many of the people or patients, they might be knowing that they have this problem, but when somebody asks, they may deny, no, I don't have any problem. But when we need to intervene, when the patient has denied, so when the patient they are against the treatment, or when they interfere with the treatment or with the symptom control or with many other things, then only we need to intervene. Otherwise, a patient may deny, but he or she may come for treatment. He says, okay, I am willing to do that, but I don't have any disease. So that means clearly the patient is not causing any problem for the treatment or any other purpose. Then in such situation, usually denial, it is more of a coping mechanism. Then otherwise, if she or she interferes with the treatment. No, I don't need any treatment, or it is not necessary. Then in such situation, you have to sit with the patient and then you have to challenge his belief.
Thank you, sir.
For the discussion point, if there is an opinion difference between the caregiver, also, especially in this case, only few caregivers versus the patient, then what should we do? We should always obey or go according to the plans of the patient, or should we?
Okay. So I think for the past a few minutes we were talking about ethics. So if you look at the ethical principles, all these were actually derived from Western society, and most of the people who are talking about ethics and wrote books on ethics are from Western countries, where if you look at UK or USA, the patient is considered as the supreme authority, and the autonomy is the most overriding principle, or the most superior principle. So even in India, if a patient is diagnosed with something, usually it is discussed with the patient's caregiver first, and then only most of the times it will not be discussed with the patient. But in UK and USA, if you discuss the diagnosis with somebody else other than the patient without his consent, then he will sue you. So that's the type of autonomy in the Western countries. But they have their own cultural problems and things there, where patient will go alone to see the doctor, and during the treatment they will be alone, things like that. But if you look at our culture, most of the patients will be accompanied by the patients, by their caregivers, and many of the family members. So what we have to understand is, all of us need to agree that the supreme authority is the patient himself. But the family also have their autonomy, which they want to exercise. It is not against the patient, but they also want to make good to the patient. But what happens is, when their interests come opposite to each other, we have to stand with the patient. But there is another problem. If you stand with the patient, then the family will be against us. So this is a very delicate situation, which you have to deal very systematically. One of the situation is usually collusion, that is hiding the usually hiding the diagnosis and prognosis from the patient. And even caregivers may tell you to give some wrong information to the patient. So which we will deal in the communication session. I think we need to stop now.
I would like to make one last comment, sir.
Yeah.
In this patient, psychological counseling should be more, I think, since she is denying RAS tube insertion or any other modalities. Psychological counselings might help.
Okay. But that's why I asked Dr. Yamini, why did the patient deny it or wanted to remove the NG tube? She said it is because of the discomfort, as well as probably it is affecting her body image. So this is a very common problem which we should not ignore, because how many of us would like to put a NG tube and go out in the public and exhibit us like that? So we should not underestimate all these things. It all depends on the personal preferences. But at the same time, the patient should understand both harms and benefits. Then if the patient takes the decision, then we have to obey it. Okay,
Yes,
Vineetha
I
wants to
agree.
say something.
No, I was telling that as a continuation of what I was talking before, we should explain, as I said, all the plus minus, but finally, whatever the decision the patient takes, we should respect that. I have seen clinicians shouting at the patients for denying to put an NG tube or a peg, or denying dialysis. Even one patient was end of life and he told he didn't want dialysis, and I saw the physician shouting in front of his relatives. So the point to take from here is they have that autonomy. We should respect that. Whatever the physician, it's our duty to explain to them all the plus minus of all the modalities. But whatever decision they finally take, we have to respect that. We should not try to impose something on them.
Sure, agree, ma'am. But there are for certain female patients, especially elderly grandmas, they are reluctant for pelvic examination, especially PV examination, especially in tumors like carcinoma, cervix. They present with very advanced stage anemia, and we know that it is due to probably a tumor obstructing, producing renal damage and things like that. But to confirm a PV examination is absolutely important, but she simply denies it. And so in such situations, what to do, whether the counseling do help.
Will she allow a female doctor to do the PV?
No. Sometimes even not even allow female doctors to. So there are situations, because social status is spanning of between. I mean, it is well spanned between the private and the government institutions. Very illiterate patients are coming sometimes from very remote areas, so they are very reluctant.
So here the doctors are in a very difficult situation. I agree. But we can only counsel because, many of the, delegates are anesthetists. They would know. We give anesthesia for this Jehovah's Witness who refuse blood transfusion. We have done even gastrectomy or, pancreatectomy, Whipples, and for such patients with Jehovah's Witness. We can't deny them. We will not do the surgery or we will not give anesthesia, but they won't take blood and blood products. So similarly, this is a difficult situation, but we have no other way. We have to respect their decision. And something important I tell is document that.
Yeah,
Okay,
we can definitely document, but the thing is that in our society, we can't based without a PV examination, how can we offer a treatment? So we are just amounting to denial of treatment. So the lot of other agencies, political groups will can take up the issue in a later stage and say that the treatment is being denied. So we are in a very. So how ethically? So do we have any moral background or ethical background for taking a consent from the caregiver and then go ahead with the procedure?
May I add something, ma'am?
Sure.
Yeah, whenever a patient is refusing any kind of intervention or examination or treatment, you should always get it written from them in the language they understand. Not that he is a Tamilian and you are writing in English. Write in both the languages and always have two witnesses. One from the patient's side and one from the hospital's side. It should never be like, the patient should not say that I didn't understand anything and all. And maybe PV, they don't want a PV, you probably can think of an ultrasound or something, but always document patient doesn't allow the PV and get it signed from the patient with the witnesses. That will save a lot of legal hassles because ultimately we have to respect what the patient says. Tomorrow you do a PV and the patient goes and complains, then also you'll be in problem. So always have two witnesses.
Yeah, there is another thing. The WHO Helsinki Declaration says consent is not an absolute. Even if the doctor documents in the case sheet such and such date, time, I did discuss or things like that. You have to document. Even the doctor's documentation would be enough. And if the patient is ready to sign it, then it would be good. And as she told, it should be in a language that is that can understand or the patient's language. Otherwise, most of the consent forms would be in English, and many of the patients would not understand even the letters of the English. Then that would be a problem.
Sir, if
Uh,
I
so
may
regarding
add, hello, yeah. So if I may add
yeah,
regarding the same patient, so for example, it's a carcinoma cervix and a PV is crucial for local staging and patients, even we have faced same issue in our hospital that females are not, even from a female oncologist, they are unwilling to get a PV done. So what we would do is we would tell them that if we would not do a PV at the first visit, but maybe get a local staging done via CT or an MR as suitable. And then before start of treatment, once the staging is established, just for a confirmation, or if there is any discrepancy, then get a PV done. So at the only once, so it would not be a repeated per vaginal examination, but just at least once before start of before start of treatment. So patients are that way a bit more compliant.
Okay, I think I have to wind up the session now. So if you have any more doubts, you can have your doubts in the group so that we can send it to Vineetha, or we will try to answer it. So thank you everybody for this active discussion on this topic as well as on patient story. Thank you, Dr. Yamini, and thank you, Vineetha, for finding out time to come for this session. Thank you.
Thank you all.
Somebody, it's over to you.
Yeah.
Thank you. Thank you so much, sir.
Yeah, thank you, Vineetha madam, for the wonderful session, and Sunil sir for the facilitation. But thank you all, and have a happy new year to all.
Thank you so much.